The average CCA mean IMT, remember I was telling you that they do over 600 points of measurements? Average of those 600 points of measurements, the average CCA mean IMT. Then what they do is they take the biggest of the big. So wherever the IMT measurement is the largest, they will then take the max region. So that average CCA max region is the largest of the whatever plaque or inflammation you have. That's the biggest bump. That's what that number means.
Let me go back and interrupt. You're getting into mean max at this point. So the average IMT is where you take a centimeter and you do those 600 cuts and you look at the thickness there. So that's where you get basically the arterial age.
Yep.
Mean max sounds like an oxymoron. It's what Ari is talking about. You take the 6 top peaks in this area and you average those out. That's why you get the term mean max. And then you look at plaque burden, which is a composite of these and what you see here, which we'll talk about in a minute. The problem is, as you see, your average, your typical person it takes a little bit of understanding to be able to interpret all of this. So what your typical person tends to walk away with is arterial age, which you see here. Mean max, you pick up a lot more potential risk in this area, and plaque burden is clearly an area where you pick up potential risk. Now let's talk about plaque burden in the comments area. So basically, if you read this, which most people don't, it will help you interpret your own CIMT if you're getting one, at least from Todd. Because we all have a little bit of LDL between the intima and media layer, we start to look at these peak areas and we say, look, if there's an area that's over 1.3 millimeters, we call it a plaque. Unfortunately, wait a minute, was the plaque the average, or I personally call it a discrete plaque. Now, if it's over 1.3, the evidence in the science that we've been talking about has shown that people that have thickness of any area over 1.3, that starts to add risk for cardiovascular events. So what Todd does in his reports is he looks at the right and left. CCA stands for common carotid artery, where they get that mean average or the arterial age. So here, common carotid artery, 0.8, no problem. The bulb, however, is where I had 1.6 on the right. You remember we talked about that from a couple of these back. Even with a competitor, they picked that up, that discrete plaque on the right, and they said 1.5. So on a comparison perspective, I'm not convinced that there's a significant difference between the 1.493 and the 1.6 that you see here. But that 1.6 is greater than the 1.3 that we talk about here. So therefore, it does confer risk. Now, the next point is perhaps, to me, the most scientifically important point when I'm talking to a patient about their risk. Is it soft? Is it heterogeneous? Or is it echogenic? Now, soft is the one that we talked about. It's the one that confers risks. It's picking up that liquid, those immune cells, those cytokines, those things that create that risk. And so when it's not soft, you start seeing little white flecks in there. Those are flecks of calcium. And that's what you see when you start to get stabilization, organization, and again, it becomes organized, connective tissues there, it becomes stable. It's not a significant risk in that space. So people say to me, after having seen my videos on me decreasing my IMT space, they say, I want to get rid of my plaque. And I would say, well, I know less than 5 people total that have actually had that happen. So that may not be practical, but getting it away from soft plaque to heterogeneous for sure is a realistic goal. And for many people, getting it all the way to echogenic is a realistic goal as well. So you look at the rest of my looks for discrete plaques, 1.1, 1.0, 1.0, and 0.8. So again, that was the only place where I had a significant plaque. Todd will often in his reports go over what he saw in the past and then give you his present reads. As you see, I basically did not have significant change from my April 2018 to my March 2019 study. Ari, any comments about the interpretation and the examples that I've just provided?
No, you did a great job explaining them. What I really like about Todd's that you brought up in the very last there is that he does show you from year to year, if you're better, same, worse. And I think that's important for people to see, because if your physician, primary care provider, cardiologist, whomever you're going, to seek for treatment, it's important to know from year to year if you're doing things correctly, or if more things need to change, or if medication needs to be added or adjusted, or if something needs to be, totally changed. So I think what's nice about the cardio risk reports is it allows you to know from year to year, better, same, worse. And, for myself, that was important to see that mine went from the soft, squishy plaque. They immediately put me on statins, and my soft, squishy plaque went pretty quickly to a heterogeneous plaque. Not quite all the way to echogenic yet. I'm hoping to get there. But, that was kind of like a woo, yay, I win. Like I went from soft to heterogeneous. And that's important because now I feel a little bit more confident that it's not so scary to me that, that this thing could rupture at any moment.
For the information of the listeners, over half of my people never get to echogenic. Heterogeneous, I'm very comfortable with, as you mentioned. I'd love to get to echogenic. I'd love for all my patients to get to echogenic, but many of us just don't get there.